Welcome everyone to our session, Stigma in Healthcare. This is Dr. Red Close, an attending emergency physician at Community Hospital of the Monterey Peninsula and lead clinical physician for the Monterey County Prescribed Safe Initiative. The Monterey County Prescribed Safe Initiative is a collaborative effort in Monterey County to promote the safe use of prescription drugs, promote safe pain management, reduce overdose, and address substance use through preventive efforts and treatment. Been regional director for the California Bridge to Treatment program since 2019. Dr. Close attended medical school at UCLA, go Bruins, completed residency in emergency medicine at UCLA, all of you Medical Center in Los Angeles. Some of you attended learning collaboratives there, and is board eligible in addiction medicine. She has been on staff at Community Hospital of the Monterey Peninsula since 2003, and I had the good fortune of meeting Dr. Close very early in the Hub and Spoke and seeing this the Prescribed Safe Initiative and the great impact it's already had. It's been having for years in Monterey County. So we're delighted to have you here.
Thank you.
And take it away.
All right. I'm very happy to be here, and I really appreciate this opportunity. As mentioned, I'm a clinical champion in my area, both for my hospital, for our region. We pulled together a tri, and we're moving into a quad county collaborative, and then as well as a regional director for the California Bridge program. So really grateful to be here. So let's start with a couple of logistics. So I'm going to move forward with the slides. And I will do more of an introduction as we get there. Just full disclosures, I have none. There you go, done. Okay. And then National Recovery Month. We just had amazing events for Overdose Awareness Day and bringing that to the community and just with open arms, making those connections. It was incredible. And so just National Recovery Month affects us all. And so just making sure we're all aware of that. And so I'm here today to talk about stigma. And it's not the sexiest topic I've talked about, I promise you that. But what I will say is the more I do this work, the more I realize that we need to address this. And our patients' lives depend on it. And so I'm asking you to work with me on this. Let's talk about this and let's have some open conversation about how we as healthcare teammates can make a difference for our patients and our communities. So first, California Bridge, I mentioned them. I'm a regional director. They helped me with the slides. And they put together so much information that it's free. It's on the California Bridge website. If you want to share a lecture on stigma or on fentanyl or on anything with your groups, it's there for everybody. So that's number one with California Bridge. And then a second thank you I have to give is to Dr. Casey Grover. He's my partner in crime in all of this. And he actually gave a similar, or some of these slides were his. He gave a stigma lecture and I was blown away with his ability to share what we can do as a community. And so with his permission, I stole some of his information and certainly his brain, because he is the brains behind our operation. So going through all the studies and all the data, thank you to Dr. Grover. I generally start with a content warning because what I talk about is really hard. Everything I talk about that is referenced, the references will be available to you to use later as you need them. But I'm going to share personal stories. I'm going to show images of drug use, paraphernalia. I'm going to talk about overdose. I'm going to talk about death. What we do is hard, and I'm just going to ask to please have you attend to your needs during this, realizing that what we do is really challenging, and there's a lot of emotion in our work. So moving forward, this speaks to me as what it's like to live with stigma every day. It's you. It's you. You know, that scarlet letter, that's something that sets you apart, either internally or externally. And we need to change this. Our patients don't need to feel that they're singled out, that they are the focus of something that is bad or wrong. So let's move forward. And objectives are really important, obviously, for CME and as well to keep us on track. So I'm going to define, when I started researching this and when Casey was working on this, the definitions of stigma were kind of unclear. It's kind of like, you know what it is, but not entirely. So we're going to go through some clear definitions so we're all speaking the same language. And then we're going to talk specifically how stigma in healthcare impacts patients and specific studies of how this has had negative impacts for patients. And then my favorite part of this, strategies. What can I do today to make a difference, not only for the patients that I will be seeing tomorrow, but for my community? You'll hear me talk community a lot, and that goes back to what Gloria was saying. That's a huge part of my work, is making sure we're all on the same team and that our patients and our community feel that. Okay, so jumping forward to the first objective, we're going to define stigma and talk about the various types. Okay, going down to the bottom of the slide. So back in ancient Greek, okay, that's where this comes from. Stigma was a scar on our ancient Greek criminals. And it was viewed as a sign that those criminals were unsafe, unclean, and unwanted. Take that in, right? This is back from ancient Greek. That's where this comes from, a scar. I mentioned the scarlet letter, right? We had to set people apart, and we had to be clear they were unsafe, unclean, and unwanted. Those are three terms I really would not prefer to use for myself, my family, and my loved ones. Just realize right there, we've thrown that barrier down. And if you get into more commonly used definitions, it's a mark of disgrace, okay? A mark of social disapproval. None of these terms feel good, okay? Keeping that in mind is how stigma impacts our patients in healthcare. There's a negative attitude or idea about mental, physical, social features, something that sets apart and has all of this negative connotation. And truly, it's differentiating. It's us versus them. And in many ways, this is kind of self-protective, right? You know, oh, those people, someone that would never happen to me or to my child or to us. It's protective in some ways, but we need to acknowledge it, because unfortunately, we can't do anything about it if we don't acknowledge it. Okay, so we need to talk about stereotypes, right? And that's part of this, that's that protection. If I label someone, or if I stick in my stigmatized view, I can separate myself from them. That's part of my protection. And so if I know what one of them is like, I know what all of them are like, right? That separation. And so there's a lot of stereotypes, a lot of negative images and connotations and ways to speak about the people we work with. And so, you know, looking down here, talking about patients with mental health disorders, right? Considering depression, obviously drug use and injection drug use specifically, even more stigmatized, right? And then as well, something such as cutting or self-harm. So there are a number of different things that this stereotype is something traditionally we've held on to into our society as a way of putting that barrier between us and them. And so there are three main types of stigma. And I'll give the clear definitions, and then I'm going to put how it makes sense in my brain. Okay. So enacted stigma is the directly experienced social discrimination. Okay. What is experienced in a patient's world, what is actually happening. We're going to talk about some examples of that. Perceived stigma is what the patient perceives, or in healthcare, what your patient perceives a stigma. Maybe the doctor didn't make eye contact with me because I have X, right? That perceived stigma. And then self-stigma is the negative thoughts and feelings that that patient or that we have about a stigmatizing condition, okay? So like I said, I like things to make sense in my own brain, and so I'm going to translate things for me as a way to keep this clear. So enacted, say I have depression, okay? And enacted stigma is my provider, my family member, my friends judge me or discriminate against me because of my depression. They feel I'm weak. They feel that I'm unworthy. Whatever that may be, I directly am discriminated against or judged. Perceived stigma is that I believe that my friends, my family members, my loved ones, my healthcare provider discriminates or judges me. It may, in some sense of reality, may not have been that way or not intended. That's what I perceive. That's really important in a lot of healthcare. It's not necessarily what was said, it's how it was received. Okay, so perceived stigma is that. And then self-stigma is how I feel about myself, my negative thoughts, shame, some disgrace about myself because I have depression. Okay. So those are three definitions. And as you can imagine, all three, two of three, any of them can be at play in any particular patient interaction and situation. Okay. So if I have depression, all of those can be happening in the same clinical encounter. And we'll talk about how that impacts the patient's health. Okay. Now, this is really interesting. Structural stigma are the differences in society that continue and build into this negative framework, right? And so there's a lot of talk right now about gender non-binary. Well, we only have male and female restrooms. That is a structural stigma. It's actually a societal circumstance that feeds into a stigmatized condition, right? Or a stigmatized situation. And considering here that substance use is one of the only medical conditions, it's also a crime. Structurally, we put people in jail for using drugs. I have never heard of my patient with diabetes going to jail for stopping and having wind chills on their way to work. Like, just never. And so considering that in our society and in our structure, this is built. And this is part of our history that we need to acknowledge head on and decide what we're going to do about it. So let's talk about our take-home point, objective number one. Stigma in healthcare, because that's our topic today, is a set of negative and often unfair beliefs about patients with a particular condition, right? And that can be enacted, as we've defined, perceived, and self-stigma. Those are examples, and then the structural stigma that plays into that. We're going to talk about all of this as we go forward. All right. So the second objective that I wanted to bring today is, let's talk about the ways in which stigma in healthcare harms our patients. Okay. And there's some harder science, there's soft science, there's a lot of objective and subjective things to all of these studies, but all the studies will be cited. And so you can reference them later if you would like. This first one, I think, really just kind of sums it up. So maybe if I stop the drugs, then maybe they'd care. Our patients believe that and feel that. And can you imagine? I mean, and this has been a big part of my growth and learning as I take care of patients with substance use disorder and with poorly controlled mental health conditions. I need to realize that this is what's felt and seen and perceived. Whether I am that person that's making them feel that way, or if it comes from decades of being in a situation, this is what they feel. This is what the people that need us the most, in my opinion, are experiencing. So if I stop the drugs, maybe they'd care about me. Okay. So just in the title of itself is really kind of mind-blowing to me. And so when we researched it in that last study, they looked at how stigma harms patients. And they actually found in the study that patients that had a stigmatizing condition, they were less willing to seek care. Okay. They would delay seeking care. And unfortunately, that would end up in worse outcomes, right? And then they ended up targeting certain hospitals or places to get care where they would receive less stigma, right? They were received with less stigma in those locations. And I have to be totally honest, I do this for my patients. I will help them target healthcare locations that will treat them better. And I tell them point blank, I've had patients ask me, will you send my prescription to this pharmacy? And I tell them in good conscience, I can't, because I know there are some challenges for my patients at that particular location. So let's work together to go somewhere else. And I probably shouldn't admit that, and I may get in trouble, and that is okay, because I'm protecting my patients. I'm not going to put them into a situation where historically my patients come back and tell me they're unsafe or they're treated badly. So I help them target hospitals and certain care locations, and I'm okay with it. While we turn the tide of how people look and think and talk and act towards our community, we still have to protect them. So, all right, so moving forward. In that same study, when they were looking at enacted stigma against mental health patients, okay, they found there were higher rates of unemployment in patients that had, where in patients in the circumstance with more enacted stigma, okay, where it was directly happening, they had more unemployment, more problems with housing, and difficulties in social adjustment. And again, I mentioned some is hard science, some is soft science, right? Yes, no on job is easier than difficulties in social adjustment. But this is what the patients were experiencing, okay? And could that be because if I have stigmatized views towards a particular patient, I'm not going to send them to talk to someone about employment or help them get into housing? No, they won't do it anyway, right? Maybe that's how this is coming through. And so there was some postulation of how this happened, but this is what they were finding. And as you move forward in that same study, in patients using substances, they very clearly, they delayed seeking treatment, they reported decreased self-esteem, and an overall lower quality of life. And it makes sense as we talk about how this feels internally to have that enacted stigma, okay? All right, so this is something that happens. I worked in an ER for 20 years. That's my primary home, but addiction medicine is really where my heart is, and that's where I'm spending my time. But I understand against medical advice as well as anybody, having lived in an ER forever. And what this study found, this is from actually a journal that I would ask them to rename if I got the choice, but understanding why patients with substance use disorders leave the hospital against medical advice. And so what they found was that patients with substance use disorder are up to 3 times more likely to be discharged against medical advice. One of my patients left AMA on Tuesday, okay? One of the reasons these patients give, and this was a reason he gave in addition, was stigma and discrimination by hospital staff. And we've all heard it. We've all heard it, and maybe at some point in our career, we were part of it, okay? The problem is when someone leaves AMA, leaving AMA is associated with increased 30-day mortality, okay? Also increased rates of readmission. That person needed to be in the hospital. They had an increased rate of death associated with against medical advice discharge from a hospital. So if stigma and discrimination is causing a patient to leave the hospital when they still need medical care, that is obviously a harm. And I think that's just really clear. And we need to acknowledge that. I mean, I used to fight with patients right out of residency. No, you can't leave against medical advice. Da, da, da. Instead of getting to the underlying problem, what's going on? How can we help? Why is this a viable solution? And sometimes literally it's totally legit. I have to pick my kid up from school. Nobody else is going to be there. How can we help you after that? Right? This isn't a time to fight. This is a time to partner. All right. I get a little passionate. Sorry. All right. This doesn't just pertain to my area of passion and interest, right? We looked at a study, and this is in BMC medicine, of over 13,000 patients with, and they were looking at weight stigma. Okay, so this isn't just for what we traditionally think, or at least what I do for substance use and mental health disorders. This is across the board in medicine, right? So in the study of almost 14,000 adults with weight stigma, people who experience weight stigma had a 60% increased risk of dying from all causes, independent of medical comorbidities and degree of obesity. Okay, and the authors were looking at this, and they postulate, again, the hard and soft science, that it's due to the direct and indirect effects of chronic social stress, right? Maybe more substance use, higher stress hormones, higher inflammation, metabolic dysregulation, right? Some external factor was associated with the increased risk of death in these patients, in those patients experiencing weight stigma. So this isn't, and you think about how many of our patients have more than one stigmatizing condition, right? And how that all interplays. So moving forward into more information that we have on how stigma harms patients. This study kind of blows my mind a little bit. Okay. What they did is this was a VA study in primary care. Okay. And the thought process was, and I'm going to read it so it's more clear. Those with stigmatizing attitudes, so a provider, right? You're a physician, right? Those with stigmatizing attitudes may believe people with mental illness are less likely to adhere to treatment recommendations. Okay. Like I said, oh, he won't do it anyway. Okay. If this is the case, then the providers may be less likely to offer some types of healthcare options to patients with serious mental illnesses. So they looked at this and they did studies to try to figure out providers that had more stigmatizing views of schizophrenia, serious mental illness, right? Schizophrenia. And so when they looked at it and patients, they took the providers and those with stigmatizing views against patients with schizophrenia and those without. And when patients presented with back pain, right? Nothing we ever see in primary care in the ER. When they presented with back pain, if you had a stigmatizing view of a patient with schizophrenia and your patient had back pain and schizophrenia, you were less likely to give that patient naproxen, okay? Anti-inflammatory pain medicine. You can buy it at any CVS, Rite Aid, or Walgreens, anywhere, grocery store. And also less likely to give them specialty referral for back care. So it's thought, the reasoning for this is thought to be that the providers, they won't do it anyway, right? Maybe that's it. Or it's just back pain. And their bigger problem is something else. Whatever it is, the patients were less likely to get naproxen if the provider had stigmatizing views against patients with serious mental illness. That took a while for me to kind of wrap my head around in healthcare. So, but it's in the published medical literature, and I think we need to listen to it and consider that it is definitely a harm to our patients. And so I'm going to summarize it. Yeah, stigma harms patients. I mean, absolutely. We talked about unemployment and housing, very tangible things you can clearly line up, but also social adjustment issues, lower quality of life, lower self-esteem, delays in seeking treatment, increased risk of death, right? So yes, I'm going to say that we have looked at ways that it's pretty clear that stigma harms patients. But one more thing on this, it hurts the population, right? So here's another study listed at the bottom. Rate of treatment of chronic diseases in the United States. We treat almost 80% of people with hypertension, okay? We treat 73% of people with diabetes. And even major depression, in the study, they found a 71% treatment rate. Addiction, 18%. So if we only treated 20% of our patients with hypertension, what kind of societal chronic issues are we going to have from that disease being untreated, right? How many more heart attacks? How many more strokes? The debility from either of those conditions. And yet, this is where we are with substance use. This is actually a high, in comparison, this is a high rate of treatment for substance use. So it's actually even potentially worse on a societal level, right? Okay. So I think that stigma, in many ways, is recovery's worst enemy. That's my personal belief in I say, I predominantly now work at a street clinic. And we literally just pop up our little tent and we take care of anybody that walks in, whatever we can do for you. That's the answer for today, whatever I can help you with. And that environment where patients will literally thank me for making eye contact with them drives it home to me that stigma is what's getting in the way of recovery for so many of my patients. Okay, so moving on to how do patients respond to this horrible circumstance we've talked about with stigma. And this study here that's listed below show there are basically 4 methods that patients use to handle this feeling that they receive and they perceive. And secrecy, okay? That's one we're gonna talk a lot about. They can choose to educate others. I can talk to my doctor about, yes, I have a stigmatizing condition, but, right? They can also challenge, right? A little confrontation, possibly, or they can avoid healthcare. And 1 and 4 are the ones, 1 and number 4 are the ones we're going to talk the most about, and you'll see why. So secrecy in this study was listed as the most commonly used strategy, almost 75% of patients, okay? And as you can imagine, if you have something so wrong with you that you need to hide it from your healthcare team, right? How's that going to impact your self-esteem? Obviously, you're going to have higher perceived stigma and higher self-stigma, right? And that's what they found in this study. And this goes back to something that is called diagnostic overshadowing, okay? And that's the misattribution of physical symptoms to mental illness. And I'm going to start with the case, and then we can talk about the quote after. So a colleague of mine saw a chart for a patient, 22-year-old female, history of anxiety, coming in with paresthesias or kind of numb, tingling, malaise, just doesn't feel quite right, okay? Sees the patient, obviously doesn't see anything clinically on initial exam, and comments, oh, it's probably her anxiety. Okay, well, we'll check a couple things, just kind of look around, right? Comes back that her body sodium, her electrolytes are completely out of whack, and she is in a primary adrenal insufficiency. Her adrenal glands basically have shut down, and she ends up in the ICU. So it's either anxiety or ICU level care, right? And it's that moment of, oh, she has anxiety, it must be her anxiety, right? The patient has anxiety, oh, that's why they're hyperventilating. It's not the fact they have a giant blood clot in their lungs. No. It must be their anxiety. And so having that label, that stigmatizing condition has providers thinking that's got to be the problem. It can't be one of these other issues. And so this study confirmed that diagnostic overshadowing can lead to misdiagnosis, right? In patients with mental illnesses, or in the circumstance we're talking about as well, even with substance use. And the patients really, they just want to have their complaints taken seriously, right? And so sometimes they will feel compelled to really, no, doctor, it isn't my anxiety, which unfortunately can break apart even a partnership in their care. So I can imagine and understand, and it was talked about in this study, is patients just want to be taken seriously. They don't want to be blown off, right? And so you can imagine, if I don't tell them I have anxiety, maybe they'll listen to me. Maybe they'll consider that something's wrong. Maybe they'll look. And so you can imagine why secrecy is chosen in this situation. They just want to be taken care of and be fully evaluated and not judged. Okay. So this unfortunately leads to a horrible vicious cycle, in my opinion, right? So I have a diagnosis of anxiety. Okay. I feel stigma about it. I know my healthcare provider might blow me off because I have anxiety. So I'm going to hide it. Okay. And then we go through the whole thing, and because either with the EHR or some other way, the provider finds out that I have a history of anxiety. Well, but then I have anxiety and I'm perceived as being dishonest. Right? And so unfortunately, now I have the stigma of my anxiety. I have the stigma that I needed to hide it. And I have the stigma that I hid a condition and I've been found out. Rinse, repeat, right? You can just imagine how this builds into the thought process of how horrible a patient can feel and what they may do in response. And so talking about that, when we look at suicides, most of those patients have had underlying psychiatric disease or disorders. And unfortunately, the negative emotional consequences, because of our mental health stigma, they're associated with that lower self-esteem, feelings of loneliness, shame, all of which are are predictors of suicidality. And so how is this playing forward, right? When patients are feeling so horrid about their circumstance and about their situation, I don't know that we'll ever know how much this really plays into attempted or completed suicide, but the predictive factors are there. Okay. I mentioned we're going to talk about number 1 and number 4 the most. And so we've discussed secrecy, and then here's avoidance. And this is a quote from this article. A young lady was explaining her situation. She said, when it comes down to it, a lot of times I need to get medical attention. I put it off and put it off and put it off because I don't want to face the embarrassment that they make me feel. And that's just not fair. It's not, right? So patients that could have come in with an early skin and soft tissue infection, dose of antibiotics, going to do great. Wait and wait and wait and wait until they come in, and it's ultimately IV antibiotics and a prolonged stay, and then we deal with withdrawal. I mean, you can see where this plays out, right? So instead of accessing needed health care, patients will avoid. And unfortunately, that can result in fatal outcomes. And this is a friend of mine, and his name was Mike. And he and I worked at the Syringe Services Exchange together. And Mike died of stigma. And I am angry that my friend died of stigma. And what happened, so we're all at the exchange, it's a Wednesday, everything's great. He's taking care of patients. He's literally getting dog food for people's pets so we can make sure that everybody's cared for. That's kind of our theme, right? Friday, Mike's getting really sick, but he can't go to the hospital because people are going to treat him like dirt. That's his experience, right? So he cannot, it's just not going to do it, not going to do it. Doesn't tell any of us Wednesday. He is surrounded by loving kindness on Wednesday. He's giving loving kindness on Wednesday. Doesn't tell any of us that something's going on. Unfortunately, when somebody finds him, takes him to the hospital, it's too late, cardiac arrest, they can't get him back. My friend died of stigma. And I got to tell you, no, I decline. We're not going to do this anymore. And that's a huge part of my passion for this topic and this conversation is good people are suffering and we need to do something about it. So moving forward and talking about, I mentioned how we were talking about weight stigma. I obviously have a lot of information and background on mental health and substance use associated stigma, but it casts a wide net. And as we were researching this, I didn't realize any of this, right? So here's a study on assessing the stigma content of urinary incontinence intervention outcome measures. Oh, okay. Stigma and epilepsy. Makes sense, right? Social stigma towards neglected tropical diseases. I didn't even know I could name neglected tropical diseases, and yet it's a stigmatized condition. And here's one on the bottom right that I'm actually more familiar with is hidradenitis suppurativa. That's basically where there are a number of abscesses that people can get spontaneously. And unfortunately, there's a lot of stigma associated with that. And it makes sense to me as a healthcare provider. These patients have recurrent infections and obviously, feeling maybe unclean and people judging them. But if you look at it, stigma's everywhere. And I ask us to consider that because that's how we're going to do something about it. Okay, so for individuals who have a history of using drugs, the impact of stigma can permeate nearly every aspect of their lives. And I think we're starting to gather that kind of information in our minds. I certainly am. Including their relationships with their family, I mentioned your friends, employers, healthcare providers. This is something we need to address on all levels, in my opinion. I love this. It's framed in my home. And in this context, there's the amazing and there's the sad, okay? So Paul made this drawing, and this was his circumstance of living with addiction. This was his depiction of how it felt to live with addiction. And because he was cared for by my colleague, Dr. Grover, an emergency physician who does not have any stigmatized views for patients with substance use disorder, they became friends, okay? Paul and Casey published articles together. Paul taught Casey all kinds of things about stigma and substance use and recovery and relapse. And it was amazing. And that friendship and that relationship changed all of our trajectory. And Paul died of an overdose. Okay? We have truly put a tribute to Paul in our work, realizing the gifts he gave to us as educators. And one of those is what he taught us about what he faced with stigma. So always tribute to Paul. Okay, so we have talked about how we define stigma. That's clear, we got that. and the ways in which stigma in healthcare harms patients. We are good. This is the part that I think we make change right now. Okay. And so what can we do? What can I do as an individual to change this? And there's a number of choices, right? We can educate here, right now. Thank you. We can talk openly. You hear how I talk about things. Like I just put it out there. Nothing to hide, not in this place. This is too important. But quality support and treatment. I'm literally on the street offering to patients whatever I can. And that quality support, not just me, but my teammate with lived experience who's sitting next to me, helping people through it, right? That's critical, right? To offer the patients whatever it is that we have. We all have a personal role in this, and we're going to take that today. Our language is critical, and then obviously in the media. As I mentioned, I would like that journal to change their name, please. We need to. This is across the board. Okay, this is one of the campaigns that I really love from San Francisco, and it talks about stigma. So 1 in 7 people in the US is expected to develop a substance use disorder at some point in their lives. So between here and Zoom, that's about 6 of us. Okay, so this isn't them, this is us, right? And this is actually even a more sad statistic, and it's actually more consistent with our clinical experience. Only 1 in 10 get care. Okay, what if we did that with our diabetics? One more time, or patients with diabetes? Substance use disorder, and this group I know knows this. It's a treatable disorder. Recovery is possible, and as we've talked about, many don't seek care because of stigma. And they put forward some ideas of what we can do, many of which we're going to talk about today. So share your personal story, educate yourself about the devastating effects, which again, we're doing now, and share messages of hope and wellness and recovery and language. Language. We're going to come all over that one. Okay. If we don't see the problem, we can't fix the problem, right? So we need to identify it. I open the eyes. Traditionally in medicine, we have not done this in a way that I would like us to have done it. Okay, so we need to look at that. What we have traditionally done, the way we've done things, we've got to change that frame. And the first part of it is looking at it and acknowledging it. And so, and I'm going to quote this: in healthcare facilities, the manifestations of stigma are widely documented, ranging from outright denial of care, right? Talk to me about the X waiver, provision of substandard care, physical and verbal abuse, to more subtle forms, right? Making certain patients wait longer, making them be seen by junior colleagues. This is part of it. This has been going on for decades. But if we don't acknowledge that and say, whoa, we're not going to make that patient wait. Oh, no. Then if we don't identify it, we can't do anything about it. One more thing to keep in mind. We may not just be harming our patients and just be harming their families. We may be harming our colleagues. Okay? So take into consideration next time you or a colleague uses a stigmatizing term, talks about a junkie, right? What if I'm standing there and I'm the other person in the room? You're going to call my friend a junkie? Really? Right? What if you're making negative comments about patients with eating disorders? What if I have an eating disorder? How do you know that the person sitting next to you isn't one of them in the healthcare environment? So realize we could be hurting ourselves, right? Talk about moral injury is to have your colleague talk negatively about something you live. So keeping that in mind in addition. All right, I get a little fired up, as I said. Okay, so, what are we gonna do? Action items, we're on it. Educate about stigma, we're here. We're gonna talk about some things with that. I'm gonna challenge you to work with and have contact with a stigmatized group. I introduced Mike and Paul as my friends. They were, and I miss them terribly because I opened my heart to patients, ended up being patients in certain circumstances, with no stigma, with no judgment, and brought them into my heart. So I challenge you to work with and have contact with a stigmatized group, and you will learn cool stuff. And then obviously we have structural and policies changes. So we'll talk about those. Okay, so let's run through each of these. One of my scribes sent this to me, and I love it. It's one of my favorite quotes. If you want to care for something, you call it a flower. If you want to kill something, call it a weed. Okay, so realize that how you use your terms is going to change how you interact with your patients and how they perceive that interaction. Okay, so we need to change our perspective, right? We all come from somewhere, either in medicine or in life, that we may have had stigmatized views. We may not be comfortable making this change, but it definitely impacts the way we deliver our care. Acknowledge that, right? You know, thinking of the patients over the years that literally we have conflicted with so terribly regarding substance use disorder, that's in the past. I need to look forward into what I can do now. Okay, so our perspectives, acknowledging that they come from this history and this teaching that we had over the years, but we can do something about it. Okay, so part of a lot of what we do in the bridge is we are trying to create a positive culture change in healthcare. Okay, we're trying to have leaders and groups and thought leaders of how we can make this better. So recognizing our own biases, person first language, which we're going to come right back to, and then be intentional in your work. Okay, and normalize caring for patients with stigmatized conditions. Okay, so I think everybody here is very clear on this. Substance use disorder, medical condition, that's just how it is. Patients with diabetes, patients with substance use disorder, everybody needs care and kindness. That to me is super easy. So we will jump forward. Person first language. I slipped up a couple of times in this talk and said a diabetic. No, it's a patient with diabetes. Okay, you're a person first. Your disease process does not define you. Okay, so I'm really good about it for my patients with substance use because that's what I do and that's where my passion is. But truly, a hypertensive, absolutely not. It's a patient with hypertension, right? Realize that give our patients that ownership of who they are, not their disease process. So I used the word junkie to make a point. That's the only time I ever hear it out of my mouth. Okay. I challenge you. It was several months ago. I was on a webinar giving a talk and whatever. And one of my colleagues, I made a comment about a urine. And I said the urine was clean. And my colleague called me out. Yay for her, right? I challenge you to do that. And you can do it in whatever way you're most comfortable. Whether it's, ooh, can you not use the word junkie? I just lost a friend to an overdose. And that word really hurts me. Or can we use a less stigmatizing word than a dirty urine, right? But truly, I am so grateful to her for stopping me. You hear I stop myself now, but if I mess up, if I use a stigmatizing term, I ask you to correct me. Okay, all right. This goes back to, well, we have always treated people this way. We've always done the us and them. It was great for my kind of moral safety, right? That's got to change. We need to own this, and there is no reason to allow bad behavior, in my opinion, on our part to continue forward. So intentional with your words and language, intentional with your actions and your interactions, and with your personal growth, right? I grow when someone tells me that is not, you could use better language. And so I think that's a big part of it. And this is an example there that I just mentioned. You know, if someone uses a term that literally, I cringe at this point when somebody says something like that. Whoa, ouch, it like stings. And I'm not the most subtle, as you can tell in the way I communicate. So I think I get my point across. And normalize the care. When I'm talking to my patients with a substance use disorder, it's normal. Let's talk about it. How can I help you? It's not, oh, you need to go talk to the addiction doctor. Right? I mean, come on. I don't tell my patients they have to go only talk to the doctor that takes care of people with diabetes. We need to normalize our care. Okay. This is huge. I mean, huge, huge, huge. We used to say, what's wrong with you? What's wrong with him? Why does he use alcohol? Right? What happened to you? Okay. Think about that. I was not trained on ACEs. Absolutely was not. I had to learn. right? That's a new concept that is critical to my growth as a provider. And so what happened to you? Was it physical abuse, emotional or sexual abuse? What about neglect? What about an incarcerated relative? Did you grow up in a family with substance use? We need to ask these questions and be ready. The answers will be ugly. I promise you. The things my patients have told me of what happened to them. I mean, I was going to share a story, and it's truly too hard to talk about, of what one of my patients went through that led to her ultimate substance use. Ask. Unfortunately, you'll learn a lot. It's a hard lesson, but it's critical to our growth. Okay. Personal tips. The first way I started doing this and really being mindful was out loud saying something to my scribe or to my nurse when we had just had a challenging encounter. Okay, there's confrontation in the room, something's not right, patient doesn't want to talk to me, whatever it may have been. And I would walk out of the room and out loud, I would say, wow, their life is really hard. And that triggered to me, wow, I'm really fortunate. I don't have to live like that. I need to be mindful that how they got to this place, I don't know, but this is bad. And saying it to my scribe and to my nurse sets the stage, right? Saying it to the patient, I am so sorry for what you've been through. And so that kind of that center yourself, sometimes taking a deep breath, but reminding yourself that there's more to this than you're seeing in that moment, I think is really helpful. I reassure my patients, I thank them. Oh my gosh, I thank my patients all the time. Thank you so much for allowing me to help you today. Thank you for coming in and letting me try to do what I can. I mean, I can't promise the world, right? I don't run health systems. I can't do that. But I'm telling you, I'll do everything I can for you today. And thank you for giving me that option, right? It's so funny. I had a nursing student with me the other day, or yesterday, in my street clinic. And she goes, well, did the patients lie to you? I said, they don't have to. Why would they? I ask how much meth you use, and they tell me where, when and how much, and like, why lie to me? We're in this together. And so that open environment makes such a huge difference. It's so incredibly rewarding on all sides. Okay. So I'm going to ask you just to kind of take a minute. How do you think about and speak about patients who use drugs? Right? Okay. And then, so what specific actions, as I was mentioning, some kind of personal tips, pro tips, we call it in my house, can you take to address stigma and discrimination in your own practice? Okay. So we talked about education, talked about how we can kind of get through this together, working with a stigmatized group. I talked about my street clinic, and I don't know if you can tell, but I just beam when I talk about my street clinic. My patients are incredible. But catch this. These are some of my buddies, right? We threw a recovery run, brought a bunch of people in various stages, yes or no recovery, it doesn't matter, just come hang out with us. I work, if not every single day, multiple times per day, I work with someone in some stage of recovery or not, right? Every single day. And those are the most rewarding relationships that I get to have. So spending that time with a stigmatized group. And I have to say, when people do that, things change. So one of my providers fought me tooth and nail on buprenorphine. Oh my gosh, it was killing me. And he stopped me in the hall about a month ago. And he was like, oh, I don't want to admit it, but you were right. It's like, excuse me? Say I'm right again. What? And truly, he got his X waiver, totally, I mean, kicking and screaming got his X waiver. And then he'd call me, okay, so this guy wants people. I'm like, oh, cool, let me help you. And we got him through it, and he started taking care of patients. And so he stopped me to say, yeah, those are some of the most rewarding patient encounters I have. I was like, oh, I win, right? My patients win. It's that whole thing of realize we are so much more alike than we are different. So, all right, structure and policy change. I'm going to make this quick. I know we're getting close on time. Yep, perfect. Okay, so we did, and thank you, Gloria, for sharing it, the Compassion Over Stigma campaign. My 12-year-old did one of these, right? She put up part of her campaign of why she chooses compassion over stigma. We post these, like, right? You post them in the hall, you post them at the hospital. Why do you choose compassion over stigma? So that's one way. We post these. Patient-facing signage. You need help with pills or heroin? Come on in. I got your back, right? Open it up and allow people to understand that we won't judge you. We just want to help you, right? Put it where it's seen. That's the answer, in my opinion. Okay, so why still do some of our primary care clinics do not treat substance use disorder? That needs to be fixed, in my opinion. Okay, we don't have the, oh, you have a left ankle fracture? Ooh, not this clinic, sorry. Right? That's not a choice. So why is this? That's a structural change we need to work on. I need us to standardize, and one of my pediatrics groups did this, by the way. Every single adolescent visit has a screening for substance use. Just that's standard. That's what we do, right? Normalize that care. Okay, talk about funding. Oh, mental health and substance use disorders. I realize these are big things that I don't yet get to control, which at some point I'd like to. But I know there are funds coming down. There are things that we're doing. Capitalize on that, make it happen, and bring this into our primary way of caring for all of our patients. And then getting patients access to care when they need it. I work on the street. I love it. That's the coolest thing I get to do. And then we just put together a substance use response team, and the requirement, the certification that you had to have, lived experience. Okay, that's who I want on my team. I need somebody that understands what my patients are going through, standing next to me as we provide care. So I shared with my providers this morning in our meeting that 2 of the patients that were recently seen in the ER are working on their peer support specialist certification and their KDAC. And I was like, paying it forward. So when we make a difference, they get to make a difference. All right. So those are our objectives. We start right now. If someone today calls it a dirty urine, I'm going to ask you to please fix that. With kindness. I love kindness. But just we can do better, and we can help each other through it. We are changing decades of not my most impressive behaviors, right? As a team. Okay. So as I mentioned, California Bridge has all kinds of cool posters and logos and tip sheets and all kinds of stuff. And so I'm asking us to think about one action. You know, I threw out a couple of things of how do you talk and speak about patients with substance use issues and what you can do. I would pick one. Whatever change is happening tomorrow, yes. And that's it from me. We'll take questions. Right, that's a really good point about how, and the question is, you know, if I have had stigmatizing views, I want to change that, but while empowering a patient, not having them in a victimized role. Yeah. So for my patients, I think that for what I do is literally partner with them in how we're going to talk about things. I ask, is it okay if I ask you about your substance use? Is it okay if I talk to you about treatment options, right? I try, and I'll take anything that the audience may have suggestions as well, to kind of put them at the center of what they're comfortable with. You know, are you ready to share that with me today? It's okay, we can talk about it later, right? Because as I mentioned, these patients have suffered so much. And I think if we can give them that power, we're taking away the victim role as much as we're allowed, and really meeting them where they are. That's kind of how I would consider it. Anything from the audience? Any other thoughts or suggestions? Yeah.
Just keeping the language really simple.
Mm-hmm.
Keeping the language really simple. Referring to them by their first name. I know when I get clients, you know, some of them are really difficult. They're agitated, and it's like I explain to the client, the patient. But I'm here to offer you some help. If you want it, if not, I'd like to give you some information, and then maybe at some point down the road, if you feel like this is getting away from you, I put my heart in there. You call me, we'll catch up. And it's, you know, and like you said, there's no reason to lie to me if they feel that there's that warm compassion. Okay, this one's listening. And just, you know, what this lady has said, is that most of the stigma comes from ourselves. I've got
Oh yeah, this was shared with me yesterday. I was on a call. That's actually why I pulled this up here. They did it to themselves. Right? One thing I found in healthcare is when we felt that we didn't have something to offer, the stigma was worse. What do you want from me? What can I do for you? And then as we developed like our bridge programs and we developed pathways for getting patients connected to care, when you have something to offer, like my colleague who was so resistant, when you have something to offer, it opens up that mindset to, no, I actually can help you if you want me to, right? Yeah.
Yeah, I think treating it as if I would treat any other disease. Would I be pissed off at them because their cancer is not in remission anymore?
Right.
You know, I have to think about it like that, and I have to get my own biases, right? And I just feel like, of course, sometimes people are gonna lie because they're scared. That's why
Right.
people lie. They don't tell the truth because they have been taught not to tell the truth.
They have to hide it.
Bad repercussions happen. So I think like treating people with just like we care about them. Like that's the biggest part.
Completely. Yeah. And just opening yourself up, you know, realizing that barrier that we've always tried to keep, right? Them, acknowledging that, you know, we're all in this together, like you said. Yeah. Any other thoughts or questions we want to cover? Oh, sorry.
They're having trouble hearing us.
Oh, I have the thing on. Hearing questions now, they're having trouble or? Oh, got it. Okay. Yeah. Well, thank you for listening. Thank you for truly for being here. Yeah.
I just want to compliment you because I'm a peer and I know you are a professional and I really appreciated how you integrated peers into the work that you did. That is very important. I really appreciate that. I'm going to take that to my team because they see the time. And I'm in the cover. So the things that you talked about today, I do those things.
Yeah, it's amazing. I was sharing with my physician group today, it's our group meeting today, and I shared with them we call it a substance use response team, the CERT, right? And they were asking, so what can they do? What can they do? And I'm like, you don't understand. What they can do is give the patient, and I know most people refer clients, whatever, I'm a doc, I call everybody patients, but they can give the patients an understanding that nobody else can. And acknowledge that as a physician. Yeah.
But then when they come, the whole dynamics of the engagement changes because it's coming from meeting that client where they are to some.
Yeah. Well, it's part of the team, right? I have physicians, I have nurses, I have social workers, I have a certified alcohol and drug counselor. I needed a peer. So that's what we did. And it was critical. Yeah, it's a huge team. It's a lot of fun, actually. We go to the street, we take care of my patients. It's so cool. Sorry. Okay, we're out of time. I apologize. I get too excited. But thank you. Thank you. Oh, good. I love lunch. Thank you, everybody.